رؤى. لا ما راح اقدم، انا بس اقول اوكي. ايه طيب دكتور اندر. ايه خلاص ابدا. Okay. Assalamu alaikum everybody. Welcome back. We will resume our lectures. Next is Dr. Andira Bokhamsin. She's a consultant radiologist and she's an area leader of primary healthcare radiology services and activist against breast cancer. Also, she's a board member of Saudi Cancer Foundation. Dr. Andira, she will present primary care perspective in breast cancer screening in Saudi Arabia. The floor is yours, Dr. Andira.
Assalamu alaikum. Thank you for inviting me in such a beautiful forum. And my talk is going to be about the role of primary healthcare centers in early detection of breast cancer. As we all know that primary healthcare can represent the base of the pyramid, because with the high population, the primary healthcare centers can do a lot. It's not cheap. Okay. Effective cancer early detection at the primary care level is certainly important. Why? Because of the high number of population. Because the success of clinical early diagnosis efforts, since more than 90% of patients' contacts within any health care system happen within the primary care level, either through the health centers, the dispensaries, or the offices of general and family practitioners. So what we are talking about here is a very high population and a very high target. Millions of people interact with the primary healthcare services on a daily basis, which provide a highly useful platform within health service in order to improve population awareness of common cancer, including our talk today is about breast cancer, to provide simple screening tests and to refer clinically the suspected patient for the diagnosis and the treatment into a secondary or a tertiary care levels. Most cancers, if they are detected at an early stage, they can be easily treated, and how would they detect it early? If the suspicion is high. And this is a load, or this is an important function for the primary healthcare workers who have, especially when they have a higher knowing or knowledge of providing the routine persons who, especially with those with the high risk factors. Breast cancer is as we talked about earlier, it's very important because of its high incidence rate, since it is the #1 cancer locally and internationally. Primary healthcare centers have involved in a very important role in early detection. Ladies are received in hospitals after they are being referred from these primary healthcare centers for mammogram screening and further evaluation. So how would the primary healthcare centers participate in the early detection? In general, primary healthcare centers play a vital role in cancer detection and screening, diagnosis and provision of timely referral for cancer services, collaboration with multidisciplinary cancer specialties team about the patient care. What is the benefit of the early detection? It is very important to discover the breast cancer at the early stage, because it will give a high number of cure rates, and it will reduce the death rate, since the cure rate can reach up to 95%. Breast cancer plan initiatives in primary healthcare. There was a specific initiative that have been developed with a focus on primary healthcare that will include strategies that focus on high-risk ladies, such as those with a positive family history of breast cancer, and the development of different pathways for primary care providers, easy to use and to understand for ladies with different health concerns. And we will explain this pathway in more elaboration. Women presenting with symptoms related to the breast cancer, to the breast, whatever it is, either related to a cancer or other diseases such as nipple discharge, nipple retraction, ulceration, or any other symptoms, they should be clinically examined within the primary health care. The examination should include both breast, the axilla, and the neck, and they should be referred for a secondary or a tertiary hospitals for further evaluation. Women found, even if they are found with no abnormalities on a clinical breast examination, they should be given first the required education in order to encourage them to do the personal self-examination, to be aware of what is normal, and if there is any changes or any abnormality, to be alert about it, and they should be advised to seek a medical care if there is any further abnormalities or any changes, and they should be advised to do also the mammogram. Unfortunately, this is not very clear, but actually it's represent the part of the national directory dedicated to healthcare workers regarding breast cancer. Actually, this directory is dedicated to all health workers, including workers in a primary healthcare centers. And as you can see, it divided the ladies according to the age between 20 to 40, and then between 40 to 70 years of age. At the younger age group, the primary healthcare centers, what is needed from them is medical awareness, education about the importance of the breast cancer and the importance of early detection and the clinical breast examination, and above the age of 40 to 70, in addition to the education about the importance of the early detection and the clinical examination, they are advised further to do the mammogram. So this is a very important role for the primary healthcare centers. They are responsible for making a list of targeted ladies in the area. They are collected, their data are collected, which include their names and their phone number in order to be contacted. And they are called if they are above 40 and they are needed to do the mammogram. They are first educated in the primary healthcare centers about the importance of what is going to do, what is going to be done for them, including the clinical examination and including the mammogram. They are then registered in the program, which is attached for every primary health care centers. They are also, more importantly, they are follow up, and they are making sure that the ladies have listened and she went and she has done the mammogram. And after the mammogram is done, what is the result from her examination? And at the end, there will be a monthly report that is recording all the cases and all the findings. This is the registry. It will show for every lady above 40 that is following up in the primary care, what is needed from her, all the data, her name, the phone number, the date of birth, when she was referred for the mammogram, and what are the findings. And this is the pathway that we talked about the important for every healthcare workers in a primary care to know that what is the lady should do, that At the beginning, she should be referred for the mammogram. The mammogram either will come positive or negative. About if it is positive or negative, once it is negative, the lady is going to be assured about her result, informed about her result, and advised to for the exam to be repeated next year. And if the exam is positive, there was some findings in her mammogram, she is referred for the hospital. And in the hospital, she is going into two pathways. Either she will go into further examination and evaluation, and either she will be found negative for breast cancer. She is then followed up and assured and given all the required treatment and returned back to the with the after the follow-up, and advice also to repeat the exam next year. And for the other category, if the lady is found to be positive for breast cancer, and then she will go for treatment. So this pathway is should be very clear for all primary healthcare centers to follow, our workers to follow, in order to achieve the required outcome from such campaigns. Usually, part of the education for the primary healthcare centers, we tell them about the mammogram, because they are our, we can say they are our soldiers. They will tell the ladies what they are expected to see, that the machine is very simple and very small. We tell them about all the different places that can be sought, where they can seek the mammogram study, how the mammogram is done. Assure her that the process of compression is not really painful, because a lot of ladies, they are reluctant to do the exam because they are afraid from this point specifically. We assure her that the pain is not too much, and it is the importance of doing a mammogram is much more important. And we tell the patient if she needs any preparation. We tell her that she shouldn't be fasting. She can go anytime, preferably after the first week of after menstruation. And if she feel any type of pain, she can take some medications just for the pain. At the end of the month, this is the registration at the end of the month of all the ladies that the primary healthcare center have referred for the mammogram, with their result after coming back. It should be registered every month. Primary healthcare centers also involved in the annual campaigns, which is the Pink Eastern Province, through distribution of pamphlets, through involvement of different activities, giving personal education, giving lectures. It's all part of the primary healthcare awareness message. Thank you.
Thank you, Dr. Andira. Really, we appreciate the primary healthcare centers' role in early detection of the breast cancer, and we hope, inshallah, we will reach a higher number of early detection. Okay, shukran, Dr. So we'll move to our next speaker. Next speaker is Dr. Mariam Al-Qarashi. She's an assistant professor and consultant breast surgeon. She has a fellowship in clinical breast oncology surgery from Seoul, South Korea. She will present to us the breast surgeon perspective in breast cancer screening in Saudi Arabia.
Thank you, Dr. Roa. Good afternoon, everyone. First of all, I'd like to thank Professor Fatma Al-Milham and Dr. Roa, Dr. Afnan, for inviting me to speak in this conference and to share with you the success and challenges for the screening program from surgeon's perspective. As you all know by now, breast cancer has been increasing at an alarming rate, and it's considered to be of an epidemic proportions, with the current estimates indicating that 1 in 8 women will develop breast cancer during their lifetimes. And in spite of the advances in technology to improve early diagnosis and an increased emphasis on educations to promote awareness of early detection, we have 46,000 women die annually of this. And a significant number of these losses could be prevented through risk reduction measure, but yet many women do not practice these measures, such as breast self-exam or receive adequate clinical screening. So the purpose of this conference is to provide an analysis of the barriers to breast cancer screening with the recommendations for future research. Those are our numbers here in Saudi Arabia. In 2018, this is the WHO report, we had almost 10,500 cancer deaths, with 24,500 new cancer cases in Saudi Arabia. The most common cancers include breast cancer, colon cancer, and prostate cancer. The incidence for breast cancer, which was the leading cancer in Saudi Arabia, with an incidence of 14.8%, and the mortality rate reached 8.5%. In the WHO 2017 report of cancer deaths, Saudi Arabia ranked second in cancer mortality amongst all Arabian Gulf countries. But the trend for breast cancer, the incidence would increase, reaching almost 7,000 cases by 2040, and the probability of death from cancer per year will decrease down to 3.4% by 2030. And this is part of the success for the screening programs. As you all know, by early diagnosis, positive attitude, and awareness, these are some of the possible measures to mitigate the mortality rate due to breast cancer. And early diagnosis, early detections, and improved treatment have been associated with reduction in breast cancer mortality in Saudi Arabia and around the world. So getting regular screening tests is the most reliable way to find breast cancer early. And cancer detected by screening would be expected to require less treatment because it's diagnosed at an earlier stage. And that's what the Swedish 2 countries trial demonstrated, that patients with small node negative cancer detected by screening had a mean 10% improved survival rate at 15 years compared to those patients who had similar tumor size, but with the symptomatic presentations. So finding breast cancer early and getting state-of-the-art cancer treatment are the most important strategies to prevent death from breast cancer. In other terms, breast cancer that's found early, when it's small and has not yet spread, is easier to treat successfully, and that's what we aim for. So with decreasing mortality and increasing cancer survivorship, the surgical management has also evolved by introducing the new techniques of oncoplastic surgery and breast conservations, and by de-escalating the management of axilla, with a focus on decreasing surgical morbidity and improving quality of life outcomes. So with these accomplishments secured, greater emphasis have been placed on the psychosocial outcomes of breast cancer surgery. With the oncoplastic surgery, it was introduced and gained a lot of acceptance among both patients and surgeons because of an acceptable appearance of the breast is more than a simple cosmetic concern. It affects the woman's quality of life. And it's been documented that women with pronounced asymmetry are more likely to feel stigmatized because of their breast cancer treatment and are more likely to report depressive symptoms, while women with minimal breast asymmetry report higher quality of life scores. So that was in terms of success for the breast screening programs and early detection. What about challenges? One of the major challenges that we face as breast surgeon are the presentation of patients being already locally advanced breast cancer. So in this year, 2021, till last month, we had almost 65 patients diagnosed with breast cancer. More than 55% of those newly diagnosed cases are locally advanced. And when asked their barriers to early presentation, it remains actually similar and have persisted over the years, despite targeted effort. So those women, despite all these awareness campaigns, they still fear the diagnosis of cancer. They preferred alternative treatment or self-medications and fear to be burdened on their family and have a lot of misconceptions about the disease. And that's why there is a need for us all to rethink of an existing strategies and to develop a new innovative ways to reach out to these group of patients. And it's similar all around the world, as the benefits of organized population-based screening programs for breast cancer for women, it's widely established, but in practice, cancer screening programs often fail to achieve their full potentials. In this figure, this is a study by Turneb et al. That brings together all barriers identified from 6 of the European countries. It shows the subsystem in which they occur. Those barriers, for example, where the screening programs and the protocols are not regularly updated, or the limited capacity of the screening organizations, insufficient monitoring and evaluations of treatment outcomes, or no follow-up, or difficulty sharing or accessing the data. This is not primarily because of ignorance about how to screen for breast cancer, but there are many reasons for this. Some would relate it to technical aspect of screening activity, and some would relate it to the ability to engage with the targeted population, which is a major concern. For us here in Saudi Arabia, within the context of literature pertaining to observational study, many Saudi community-related factors can contribute to the escalating burden of cancer. These increasing trend may be due to changing lifestyles, lack of awareness, embarrassment, and fear of testing or non-accessibility to advanced treatment, and it's due to multiple factors. The effective techniques of screening and diagnosis using modern upgraded instruments may minimize the burden of cancer in Saudi Arabia, but we should all work on improving the health component of cancer patients through implementing an effective cancer-related health management strategies, such as prevention, early detection, and proper treatment, which in turn would decrease the cancer morbidity and mortality. The other challenge that we face as surgeons is overdiagnosis. Overdiagnosis is an ongoing debate nowadays, and it's related to screening. Although there is no single definition for overdiagnosis, it can be understood as the diagnosis of a condition in an asymptomatic person that does not produce a net benefit for the patient. i.e., overdiagnosis is not misdiagnosis, but rather it's the concept of cancer being diagnosed during a patient's lifetime that would not impact their life if not detected. The existence of overdiagnosis due to mammographic screening is now widely accepted, but the estimate is very difficult to it's very difficult to estimate the rate of its occurrence, and it's very conflicting. So an assessment of risk versus the benefit of screening, the European Working Group have concluded that there is still benefit, of course, from inviting women 50 to 69 years of age for screening. But on the other hand, overtreatment of the screen-detected DCIS is one of the consequences of overdiagnosis. Till today, there is no way to differentiate between DCIS that will progress to invasive breast cancer from that which will not. And for that, we have an ongoing trial which to address the overtreatment of screen-detected DCIS, the LABC trial, and we're waiting for its result. This trial, it's a phase 3 trial to randomize women with low and intermediate grade of screen-detected DCIS to surgery or to active monitoring. And the result of this study will help to identify early breast cancer that can be spare surgery, actually. So providing information about overdiagnosis and overtreatment to women who participate in a breast screening program will help them to make an informed decision about the time and frequency of their breast screening. So to conclude, the detections of a breast cancer in an early stage has improved survival outcomes. Advances in research relating to breast cancer surgery, such as the management of patients with positive axillary lymph node, are continually improving, along with the oncoplastic techniques that have improved the management of patients who undergo breast-conserving surgery. On the other hand, the evidence about the overdiagnosis and overtreatment are challenging to screening. The recognitions of early breast cancer detected by screening, which will not progress to an advanced disease, is the key to select the patients who would benefit from surveillance instead of surgery. So as we look into the future, we must know that screening is secondary prevention. And over the past 2 decades, primary cancer prevention in general has increased with lifestyle changes, immunizations, chemopreventions, and even prophylactic surgery. And actually, the largest reduction in cancer death in the United States is not due to screening, but it was due to decrease in smoking, lifestyle changes that public policies helped make possible. And we can use that in breast cancer, as in chemopreventions to reduce the incidence in women with elevated risk of breast cancer, or even prophylactic surgery that would dramatically decrease the incidence in women with the BRCA1, BRCA2 mutation. All of these primary prevention approaches are likely to be more and more successful and to expand to other cancers as research progresses over the next several decades. So screening has been important in the fight against cancer, and it's still likely to continue to be important in the years to come. Nevertheless, progress in primary preventions and treatment should over time decrease the need of cancer screening. And we should all look forward to the day when better strategies for primary care preventions and more effective treatment in order to reduce the need for cancer screening that can be relegated to medical history. But till that time, our goal will be always early detections by screening. Thank you.
شكرا دكتورة مريم for this very يعني an informative talk, and I have few questions for you after we finish from our next speaker. I'm so proud to present my dear colleague, my daughter, my one of the very promising radiologist, not in the kingdom, but inshallah in the Middle East, Dr. Afnan Fahad Al-Mahanna. She's an assistant professor of radiology. She has a fellowship in women imaging, breast, and she's head of breast imaging unit in King Fahad University Hospital, جامعة الإمام عبد الرحمن بن فيصل. تفضلي دكتورة أفنان. She will talk about breast cancer screening and the ugly days of COVID-19. تفضلي دكتورة.
Thank you, Dr. Fatma, for, as usual, nice introduction. I'm glad to present this talk to you. You know that COVID-19 crisis was a new experience for everybody. It ruined our routinely life, and hence it affects every domain in our life. So my objective, I will go direct to the COVID-19 journey. I will try to explain the war between the virus and the world, COVID-19 and Saudi Arabia, and impact of virus on breast imaging division. As you know, COVID-19 started in December 2019 in Wuhan, China. In very short time, it was spreading everywhere through all continent, and unfortunately reached Saudi Arabia in March 2020. Our region was the earliest, or one of the earliest region affected by this virus in Saudi Arabia. The main aim initially was to flatten the curve, just to give a chance for the healthcare system to cope with this pandemic. Saudi Arabia government act very aggressively against this virus and this pandemic, and they start with many. They announced many initiatives through WHO Command and Control Center and Wiqaya Center as well. And early on the days of COVID-19, also most retired doctors and nurses were called back to overcome the needs of physician. Those strong regulation give a bit of a flattened of or slow rising of this upslope of COVID-19. We can see here very clearly the data from day 1, which is March 14 to July 4. Many guidelines were initiated, even with the through media and Ministry of Information. We have many applications that makes our life much easier, and we can control the preventive practice like social distancing. We have the توكلنا, تباعد, and we have COVID-19 guidelines for the healthcare workers. Many initiatives were also conducted to just maintain a smooth going back to normal life. So we have the we are all responsible and we have نعود بحذر or return carefully initiatives, which is mainly of education of people and the community to go back to their life, but it is not the usual life they have to know. So they need to wear masks and they need to use hand sanitizer, no handshakes, and maintain social distancing everywhere. Then we were having like a daily reports from the WHO regarding the numbers in Saudi Arabia and number of deaths, and compare it to the international levels. Saudi Arabia was very very strict in the regulation initially. They stopped a lot of there were travel banning. We stopped a lot of activities, and they spread also a lot of pamphlets in different languages, not only in Arabic, English, Urdu, for all Saudi citizens, not only the Saudi, those who hold only Saudi nationalities. So this pandemic is also affecting hospitals and also the screening program. I will go just briefly to introduce what was the history of breast cancer detection and screening in the Eastern province and in Saudi Arabia. Everybody knows that we have still young screening program. The first initiative in Saudi Arabia was back in 2007. It was through non-charitable center, which is Abdul Latif Charitable Center with Saudi Cancer Society back in 2007. Then 2 years after, new initiative were started in our region in the Eastern province with our university, which is the MAM University, IAU University, and Saudi Cancer Foundation. So then after 4 or 5 years, the national screening program initiatives comes to light. So it was a very older initiatives in Saudi Arabia before 2015. Since the start back in 2009, we commit ourselves to do cancer campaigns everywhere. We can see that we still having this very beautiful balance, and we try to spread information in very simple lay language to the community. And it is a habit of every October, and we call it Pink October أو شرقية وردية. Then it's changed to be ما يعرف بعدين. Every October we highlight also, or we lightened our university hospital with this beautiful pink ribbon just to call people to come and to do screening. So since 2009, we commit ourselves to do screening program despite all obstacles till we face the COVID-19 crisis, when all screening program, not only in our area, worldwide, the screening program scaled down, and went to temporarily shut down, and we can notice this from the earlier presentation by Dr. Leila, Dr. Khalid from Qatar, and Dr. Najla from Egypt. That time, our hospital administration were conducting different meetings, and they asked every department and every division in the hospital to plan for how to deal with COVID-19. COVID-19 changes from just a physician to a manager or crisis. We learn crisis management or disaster management. So we comes up with this paper, which was published early April, which is very I'm proud to say it is very soon in this COVID pandemic, and one of the prestigious the Breast Journal. Our aim, the primary aim, was the primary aim is to ensure the safety of our patient as well as our staff, and to cope with the hospital shortage of PPE. So we plan our operational plan depend on those two major aims. We have a general recommendation like other areas in the hospital and other areas in the community, which is an implementation of the social distancing practice. So we try to give a more time for mammographic examination, and we have like a time slot between each mammogram study and the other. We have like a 10-minute interval and 15-minute interval between interventional and MRI procedures. And we also extend the operation hours. Instead of doing like from 8 to 3, we extend it up to 8 p.m. All breast imaging studies with COVID positive patient was delayed. We try to do a phone call scheduling instead of a patient coming or physically present to radiology front desk. All patients should be masked upon the hospital entrance, and hand sanitizer are there everywhere, and we ensure also adequate supply of PPE for all staff. We do a lot of remote consultation through smart call with our colleague and video call, and we are one of the earliest staff who start with virtual multidisciplinary meeting and educational conferences. We practice also social distancing in our reading rooms and waiting area and radiology front desk. Because we are academic institute, our teaching is completely turned out to be through Zoom video communication or video conferencing. During that time, we have a good time for research, and we encourage our students to participate in research. And we design our reoperation plan to 3 different phases. The first phase, which is, we call it a diagnostic reoperation phase, we did only the urgent cases. And for the phase 2, which is a high-risk screening reoperation phase for semi-urgent cases, and phase 3 screening for reoperation for non-urgent cases. Phase 1, we enhance, it is simply a diagnostic, or what we call it an urgent cases, those ladies who needs an urgent referral. During this period, we enhance a walk-in clinic. We try to do a simple referral. Once they have it in the clinic, they can refer patient directly to radiology and to do all her investigation at the same time. We accept only, we make an urgent follow-up appointment for clinically suspicious cases, and we also make urgent appointment for BI-RADS 4 and 5 biopsies. For those ladies receiving chemotherapy, we schedule their follow-up ultrasound at the same day of her next chemotherapy cycle, instead of doing 21 days assessment. And we resume BI-RADS 3. And we try to limit the diagnostic MRI for those cancer proven, those who have type D and type C breast. And we revised the MRI protocols, and we try to make it shorter than the usual MRI protocol, just to enhance the MRI workflow. For the phase 2, we call it a high-risk screening reoperation phase for semi-urgent cases. We try to recall patient, those who we know that they have high to intermediate risk, or those with treated cancer for a long time. Still, we categorize them as a high-risk patient. And we resume screening MRI, and we try to use the 10 minutes protocol, or what we call it, the abbreviated protocol, instead of doing the full MRI 30-minute protocol. For phase 3, which is the normal, but we cannot call it the normal screening. It is just a normal in the era of COVID-19. So we do the routine screening, but again, under very strong or very strict regulation provided by the hospital administration and infection control department. So how long this 3 phases take from us? Each phase takes 42 working days, which is equivalent to 2 months. And we can see that we resume our normal scheduling like in 6 months. So most of our, as you see, most of our cases at the beginning, it was a diagnostic 0 for screening in phase 1. In phase 2, again, we concentrate more of high-risk screening, and we are doing also diagnostic. In phase 3, you can see that the screening is a bit higher than the other phases. So we try to balance, and finally we are back to normal, but again with COVID-19 restriction. And we published this project in Suleiman Al-Habib Medical Journal. Now we are at COVID-19 vaccine era. So most of radiology department, they recommend to do like a 6 weeks appointment after receiving vaccine for the routine screening, just not to overcall lymph nodes as a suspicious. So we try to, if we call a patient and she's coming for only screening, we try to postpone her appointment 6 weeks after receiving the vaccine. For diagnostic, we do it independent of timing of her vaccine. But if we notice a lymph node that it looks radiologically reactive more than malignant, we call it like for 3 months follow-up. In conclusion, this COVID-19 era crisis, teach us a lot of lessons. We know that we are not only a physician now. We are leaders, we are crisis management, administrative leaders. So we need to keep our eye open for the upcoming changes with the COVID-19. So I think COVID-19 teaches us a lot of lessons, and we need to be happy about this rather than just blaming or feel sad about this bad time. Thank you, everybody. Thank you, Prof. Fatma.
Thank you, Dr. Afnan. That was really inspiring, how the hospitals and the service departments stand up in the face of the crisis. We had 3 interesting presentations from 3 different specialties. We had a presentation by a radiologist with eye of the radiologist in primary care, and we had a very nice presentation from a surgeon, and we ended it by a presentation from a radiologist in the facing corona. Anybody has a questions before I start giving questions? No, nobody would like to. Okay. My first question to Dr. Andira. What was your impression about the relation of radiologist and the primary care in our region, at least?
Yes, doctor. Well, it should be a collaboration relationship, because we have a role in educating the primary healthcare, let's say not only the physician, but all the workers in the primary healthcare, about the importance of the mammogram screening. And as I mentioned, how it is done, what are the required things from the ladies in order to encourage them. Actually, in my various lectures I have given to different primary healthcare centers, I keep telling them that you have to know the art of persuasion. You have to to convince the ladies about the importance of the exam itself. And if she is having any questions, any hesitations, you have to know how to respond to her questions, how to really convince her to go ahead and do it.
Thank you, Dr. Andira, Dr. Afnan, Dr. Ru'a, Dr. Mariam. Would you like to ask Dr. Andira anything? Okay. Dr. Mariam, you mentioned that the highest mortality rate in the region we come as Saudi Arabia number 2. Number 1, Qatar is number 1. Number 2 is Saudi Arabia. And we are considered to be a very rich country. And I'm dead sure, I know that the 2 countries provide the best kind of healthcare. And I'm dead sure that we have all the infrastructure, not the infrastructure alone, but the highest standard of medical care. In your opinion, why is that?
Thank you, Prof. Fatma. I think we still need to work on primary prevention. We need to work on public health awareness and promote healthy lifestyle changes, increase the awareness of the public in terms of when to seek medical advice, in terms of decrease the risk factors that we can change, such as smoking, lifestyle modifications, physical activity, and of course the secondary prevention, such as screening programs and awareness.
Dr. Afnan, we had a tough time with COVID, but that showed us that we had a lot of weapons to confront with anything will come. And I think I'm so proud to be a Saudi, because I think if I'm allowed to give numbers, I think we are number 1 on what we did in COVID, what the support our government gave, يعني بقيادة ملكنا الله يطول عمره. And I think the thing was provided to everybody living in Saudi Arabia, not only the Saudis. It's a source of really, يعني I'm so proud. I'm so proud to be Saudi. Everything is affected by COVID. However, the healthcare was not. We were standing so strong by the support given to us from our يعني top management. Do you have a final word to say regarding your mission, COVID and screening?
The final word that we need to know that our numbers doesn't affected by COVID-19. If we compare our statistics from 2016 to the last year, actually we have like just less than 15% reduction in our services in breast imaging department. So COVID-19 gave us more time to think, and we found that in many aspects we are followers, but as Dr. Fatma mentioned, now we think that with the COVID-19 we are leaders. So and we should think and we can initiate a different thought and different workflow. So we adopt a different workflow with COVID-19, and I think it shows a good outcome so far.
We reached to the end of this very, very rich day. I would like to conclude by breast cancer is not our battle alone. It's the battle for all women in the world. We have to be ready because all the studies says that it's not increasing by 101 or 200 by 100, but it's coming by the next 5 years, maybe 300 times it will increase. So we have to be ready. All the presentation showed that still there is, in spite of a big effort is done on most of the Arabic countries. However, still the women needs more work to convince them to come for screening. And this would never happen without having a multidisciplinary approach. We have to educate the educators. But I have one good news to all of us. I think, yes, these hamalat or whatever we can call them made a change. However, this is not the change we hope for or we would like to have. When we started Hamalat in the early 2000, the Saudi Cancer Registry, the local stage was around 13%. Now we reached to 38%. So there is a change. Definitely we did something. However, we hope for the better. We hope that we can reach every house, every lady, because this is not only for ladies. We have to educate our المجتمع حقنا has to be educated. We have to change something, positive change in our we have to add a positive change in our community, because this is our mission. We are blessed to have this education. We are blessed to have knowledge, and this is our role. We have to implement our knowledge to change and to have a positive change in our community. I really thank everybody for the participation in this meeting, and you are all the cause of success of this meeting today. Myself, I really enjoyed it. I enjoyed your presence. I enjoyed our colleagues through the Zoom. And thank you for all the attendance. Our attendance reached above 95. So that was only in the morning. So until we end the first session. And I'm so happy. Corona did not stop us from giving knowledge to people. So thank you for the attendance. Thank you for you ladies and gentlemen who presented and who attended our meetings. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you join tomorrow with us. We have a good session inshallah for the public. So see you ala khair inshallah. Allah ينهي الغمة ونتجمع physically together. Assalamu alaikum wa rahmatullahi wa barakatuh.